Good afternoon. Excuse me. We're going to be talking a little bit today about aerosol therapy. Any of you guys who know folks who take breathing treatments, this is one of the things we're going to talk about. You can take your breathing treatments, either an SVN, a metered dose inhaler, DPI, whatever. So we'll take a look at those and see how do we use those. First of all, we want to look at what are the advantages of doing aerosol therapy. And these are some things that we talked about when we did pharmacology. These are some of the questions that we saw the last time we talked about a little bit about aerosols on the last PowerPoint. What helps us with these, the doses are generally smaller than systemic doses. We get a much faster onset. And especially with our SVNs, we get an even faster onset. And people say, well, how do you know that? How do you know that you got a faster onset with that small volume nebulizer than you did with the metered dose inhaler? And part of it is your patient assessment. We see as patients are taking their breathing treatments that they begin to relax a little bit. We see the heart rate go down. We see their respiratory rates start to settle out. When we listen to them, their breath sounds are becoming a little bit more loud in some cases, a little bit more clear in other cases. So we do get that positive side effect from that. We deliver the drug directly to the lungs. This is vitally important. This is where we want it to work. And remember, we talked about the particle sizes. So we want to make sure that our aerosols are within that particle range so that we can deposit it in the lung and get the results of it. We decrease the systemic side effects. There is no way to get rid of them totally. The VA many years ago had a clinical study on the effects of corticosteroids, inhaled versus systemic. One of the things that they found was that even though they did it with the metered dose inhalers, we still have some of the systemic side effects from the corticosteroids. But they're much less than if we gave you tablets or syrup or something like that to take. Their therapy is less painful, and it is relatively comfortable. You are, though, going to find patients out there who do not like SVMs. They'll tell you it takes too long. They'd much have something that they were able to use for a much shorter period of time. Disadvantages with lung deposition, we only get a small fraction of the total dose. If you remember from pharmacology, you're looking at something around 10 to 20%. The newer equipment that we use is actually starting to increase some of that deposition for us. And as a result of that, we're getting shorter treatments now and still getting the effects that we need. Different things can affect deposition and dose reproducibility. Remember, we talked about particle size, we talked about temperature. Technique is a big one, and we're going to talk about how do we do those techniques. Lack of coordination with your pressurized MDIs. We have patients out there that we try to teach. Unfortunately, sometimes they're unable to be taught on how to do an MDI properly. We also have patients who just cannot use an MDI for love or money. And even when we're using our spacers and holding chambers, they still have some issues with it. And as a result of that, they're not getting the medication they need. Another disadvantage, and it's not on the slide, but one that we have to go ahead and make sure we understand, patients have a tendency to overuse their MDIs. They're so easy to pick up and use. And as a result of that, we're going to see a lot of side effects because there's a lot of medication in the body at that particular point. There's a lack of knowledge on how to use them. One of the things, they did a study one time, and they found out that we were the best instructors on it. We need to make sure that when we have our patients and they get their medication, especially new medications, that we go ahead and make sure that we re-instruct them. When you're in the hospital, a lot of times you can ask your patients, can you tell me how do you use your medication? How do you use your equipment? Do you know how to do SVNs? And then we just go ahead and instruct them, and then we watch them while they're taking their treatments and make sure that we can straighten anything out that we need to at that particular point in time. Patients get confused. Drug manufacturers are coming out with new devices all the time. The patient gets used to the older ones, then you hand them something new. If you do not educate them, they don't have a clue what they need to do, and so we have problems with that too. And then clinicians sometimes don't get the information they need. There's really not as many visits, I think, to the doctor's offices with their samples anymore. I know they still do that to a certain extent. However, we have clinicians who think they know how to use this that will sometimes not listen to us as a result of that. The patient's not getting the information that they need. And then one more thing that also applies to us and affects to us, we need to keep up with what's coming on the market. A lot of times, though, these new medications are on the market. We see them on TV, we read them in a magazine or something, and that's our first introduction to them. So we need to keep up on those. We need to keep up with the techniques of how to use them to deliver the medication to the patient. So some of the equipment, we have our jet nebulizers, the most common. They use Bernoulli's principle. One of the articles I was reading said actually was Venturi. It doesn't really matter. They're both the same. You have the lateral pressure that decreases. The fluid is drawn up a capillary tube, reaches the gas stream, meets the baffle, and is shattered into smaller particles. So we have smaller particles to get them into that MMAD range where we want this medication to penetrate and deposit. Now the question is what's a baffle and what does a baffle look like? A baffle is anything that those particles can bounce off and they'll cause them to break into smaller particles or put it back into solution and let it come back and then meet the baffles again. So baffles are designed just to break down that medication to keep the particles in a better range for us so that we can deliver the meds to where they need to go. An atomizer is really a nebulizer without baffles. When I describe atomizers, if you think about the WD-40 cans and they have that little capillary tube that comes off, there's no baffles in there. All you're going to do is just shake it up and then deliver it. We actually use that type of system when we're numbing up the back of the throat for bronchoscopies, sometimes other issues where they're going to go down into the airway, and it's just a baffle. If you're not sure about that because you've never used WD-40, if you ever watch Western movies, the young ladies are getting dressed, pull up their atomizer full of perfume, and they spray it on them, okay? And so that's what an atomizer is. Okay, so our equipment, basically pneumatic aerosol generators. Remember, anything with pneumatic is gas, okay? So they require some kind of a gas source, and we are sometimes the gas source. You have our large volume nebulizers, we have our small volume nebulizers. The difference is they each hold different volumes. The large volume nebulizer, anywhere from 30 on up as far as mLs of solution. Small volume nebulizers, we look at them, they're somewhere around 6 mLs is what they hold. So very, very small amount. We have our metered dose inhalers. We're going to talk about those. That's the number one way that we do prescribe our medications. We have our dry powdered inhalers. They're becoming a little bit more sophisticated. And the newest one on the market is the ResMat soft mist inhaler. There are some of the drugs that are in there, much, much easier to use. It's just a matter of the cost and getting them for the patients. With our large volume nebulizers, we can heat them, and these are just some pictures of heaters. If you notice, they're round on 3 of them, and we call those our donut heaters. One of them does have a little temperature control. The one in the middle is the one that we have. It was the one that we used when I was working, and it has no temperature control. And that's why it's so important to make sure that we put a thermometer in line. Remember, the thermometer goes proximal to the patient. So what's the difference between a nebulizer and an atomizer? Well, basically, our nebulizers deliver medications, can take up to 10 minutes sometimes. The reason it takes longer depends on the number of medications we put into the small volume nebulizer. Atomizers deliver medication instantly. We use it on the back of the nose. We use it in the back of the throat. Wherever we want to deliver it, we can just aim and shoot. And then go back to that WD-40 can with the capillary tube. That is an atomizer. So their atomizers can deliver more than just medications. in addition to WD-40, if you use cooking spray, that's also an atomizer. And they don't contain any baffles. Okay, so again, a little bit about atomizers. They're used to administer our sympathomimetic drugs, anticholinergic, anti-inflammatory, a lot of them anesthesia. It applies to the nose, mostly in the anterior nasal passages, clearance to the nasal pharynx, and the spray pump produces aerosols. And we don't break them down, and because of that, we have the larger particles. If you go to Chewy's to eat and you're sitting outside, and you're starting to feel that nice mist that comes off of their cooling system, that's an atomizer also. It's because it's still just delivering a mist to you at that point. So large volume nebulizers, we talked a little bit about this in the last PowerPoint. Why do we use bland aerosol? Remember, a lot of it was because of upper airway issues. You don't necessarily have to be on oxygen when we use this. We have patients who have bypassed upper airways. Remember, one of the major reasons that we use humidity is because of bypassed upper airways. We need to make sure that this patient has moisture, okay? And they come in if they don't need oxygen. We're not going to use oxygen with them. We just hook it up to the airflow meter and then set it to where it's comfortable for them. The use of your hypo and hypertonic solutions, remember those are either greater than or less than the 0.9%. That's normal saline. As you can see here, it is for inducing sputum. So for the MMAD has to be between 1 and 5 microns is what we're looking at. And then the use of heated aerosol, we have to increase the humidity, and we especially have to do that with our patients who have the bypassed upper airways. A lot of those guys don't have the humidity that they need, and so we need to make sure that we go ahead and provide the heat and the moisture to be able to keep those secretions looser, or at least make them much looser for them. This is a picture of large volume nebulizer again. Most of them are the same. They all work basically the same way. You have a disc flow meter inlet, variable air entrainment port. This is where you would set your FiO2s or open or close the ports if you're using enough medical air. You have the orifice where the gas actually ends up in, and then you have an outlet port to where it's going to the patient. Just like with the humidifiers, it has a capillary tube. In this case, they call it the siphon tube, a water reservoir, and then a filter. Whenever you set up a large volume nebulizer, either cold or hot, it doesn't really matter, you have to have a drainage system in line. Why do we need that drainage system? And the reason is because if we don't drain the moisture out of the circuit, what's going to happen, or the water out of the circuit, what's going to happen, it's going to give you a downstream obstruction. Remember, large volume nebulizers, high flow equipment are affected by downstream obstructions. What happens is you decrease the flow going to the patient. You also increase the FiO2 because you're not entraining enough outside air to go ahead and dilute that oxygen that we're delivering. When we do place either a drain cup or a drain bag in line, it's at the lowest part of the system. So what you do is you're going to take your large volume tubing, your large bore tubing, go ahead, set it up, then figure out where the lowest port is. You cut the tubing in half, and then you can connect it to your drain cup or your drain bag. The drain bags have a little drain in them, which is really good. You can just put it over the garbage can, or you can just empty it into a cup and then put it in the sink, get rid of it. The drain cups sometimes have a little port on there where you can actually suction it out. A mechanical vent, you're going to see in some cases they use two. They'll put one on the inspiratory line. They'll also put one on the expiratory line. If you have a heated circuit, and that's a circuit that has a heating wire going through it, you can't use these because you can't cut the heated circuit or the heated wire that goes through them. And so we have to work out something else at that particular point. It's interesting if you walk into a patient's room, because we also use these on the general floor. If there's water in the circuit, every time they take a breath, you can actually hear the water. Once the water gets too high, though, in the circuit, you won't hear anything, and your patient's not going to look good. That's an indication that you have a problem. So the Babington, or it's one that came out with it, the Solo Sphere Nebulizer, actually came out in 1972, and it was interesting to read the articles that talk about it and how good it was. People were saying they could produce a really nice mist and, gave us a little bit better control over what was going on. It did have an outlet. You can see that little green portion that stuck on the end of the part that's sticking out, lack of a better word for it at this point. That is your FiO2 controller, and it is a nebulizer, so it works out really well. So it has the dis outlet, it has capillary tube, all the other things that go with it. What made it really effective, it has two baffles, and they're little glass balls, and the water would get dropped onto these baffles, and the air would come out of them and then break it into a smaller particle. We didn't heat these. However, look at this, guys. It's 90% of the particles in the effective range. Very, very effective, and that's why people thought, wow, this is a really, really good nebulizer. We actually have one of these in the lab. I'm constantly making sure that it stays there because I don't think we're ever going to see it again. This is basically how it works. It talks about the fact that you're bringing the water up. You can see it's going to be dropped onto the baffle, which is that little tiny glass sphere. And then the other glass sphere is where the water is actually being dropped on it. And the air is coming out of that sphere. And as a result of it, that air is now breaking down the water and putting it into the appropriate size to deliver this to the patient. The ultrasonic nebulizer, this is the one that you actually plug in, and it's what converts the electrical energy into the mechanical energy. There's all different types and sizes now. Why do we use them is they are used to provide moisture, especially for folks who have really thick, tenacious secretions. When we used to have these, we would not use them for medication delivery. It broke the medication down into too fine of a mist, and it wouldn't stay in suspension. Remember, to get the medication into the lungs, it has to be between the 1 and 5 micron range. In the lower airways, it's about 1 to 3 or 1 to 2, depending on the books that you're looking at. It can provide up to 6 milliliters per minute of nebulization, and that is really a lot of nebulization. We don't heat this, but because it has the energy in it to it, the longer you use it, it starts to pick up some of the heat. So you'll get some heat in the water, and that can affect the medication that's in the medicine cup. As I said, it's extremely efficient. 95% of the particles are in the effective range, somewhere between 1 and 10 microns. Particle size is controlled by the factory, and it's the frequency. When we buy these, we buy them for the frequency, okay? We don't adjust it at that particular point. This one is showing you a little bit with the mist, and you can see there's a lot of mist that comes out of this. Output is controlled by the amplitude. The amplitude is something like a wave, is probably the best way to talk about it. At the lower amplitudes, we don't get that much of an output. When we start turning it up, we do get quite a bit of an output. We get quite a bit of a mist. And as I said, we don't normally use it for medications. The particles are really, really fine. Plus, it can also heat that medication. We actually now have ultrasonic nebulizers that we can put in line with our mechanical ventilator patients. We'll see this used a lot of times with the kids, more so than with the adults. You can set up an ultrasonic nebulizer, you can give a treatment to a patient, and then switch them to the ultrasonic nebulizer afterwards to increase the amount of moisture so they can develop a good cough for us. Very easy to work with it. What you basically have at the bottom, you have what we call a coupling chamber. And in that coupling chamber is tap water. And why do we use tap water? Well, there's a little crystal. It's called a transducer or piezoelectrical crystal. This crystal, in order to operate, has to have the minerals from tap water. And as a result of that, if you get something and someone goes, no, we're just going to use sterile water, it's not going to operate. Okay? So the water is put into what we call the coupling chamber. When you turn the device on, the ultrasonic nebulizer, if you don't have enough water, you're going to get a message that says the coupling chamber doesn't have enough water, basically. And so you just go get a cup of water out of the faucet and you go ahead and put it in there. The gas goes in. It almost works to a certain extent like your Passover humidifiers. Part of it is the medicine cup sits on top of that crystal, and it's the vibrations of the crystal that start to break down the particles as they do go through. A gas source, you either have a fan or compressed gas, moves the aerosol particle from the unit and then delivers it to the patient. So there it is, large volume nebulizers. Like I said, we can use them for our patients who have really thick secretions. We need to get them out or help loosen them up for the patients. So we can use as a blend aerosol therapy for sputum production. Small volume, we use them for aerosol drug delivery. We do use those a little bit now. And like I said, most of those appear to be with the pediatric patients. The small volume ones don't have a couplant. The drug is just placed exactly on the transducer, so it's broken down by the vibrations of that transducer. Okay. This is a picture of a small volume ultrasonic nebulizer. We use with mechanical ventilation. You can see the crystal at the bottom. Just remember, crystal is also called transducer. Then we have the electric part that goes and has the electrical energy that then is turning into mechanical energy, and there's your vibration as far as that goes. Very, very easy, nice setup. A lot of these nebulizers are really, really good. They don't add any weight to the circuit. The newest one is your vibrating mesh, and this is either active or passive. It increases the medication delivery, much, much more interesting. It does not add any weight to the circuit when you're delivering your medication at that point. It's a good device. One of the articles I looked at, they did a research study in 2019 to see what was better. Was it the vibrating mesh? Was it the small volume nebulizer? Or was it the large nebulizers, the jet nebulizers? The overall conclusion from that article is that the vibrating mesh nebulizer is a good nebulizer. In some cases, it is a little bit more effective than either the small volume nebulizer or the jet nebulizer. However, when you came to the end, and this was basically in your emergency department they were doing it, the results were a lot of times the same. So it didn't matter one way or the other, just depending on what you're doing. So this is a small volume nebulizer. You can see a picture of it. The picture showing you the small bore tubing, the nebulizer cup itself. You can see it's very small. We also have a T-piece on top of it. On one end of the T-piece is your mouthpiece. On the other end is your reservoir tubing. We want the reservoir tubing to keep the medication from leaving way too fast. If we need to use a mask to deliver our small volume nebulizers, we just take that T-piece off and the mask fits right on top of the little nebulizer cup. Works very well. Now you're going to hear when you talk to people, they're going to tell you all of these treatments need to be given by mouthpiece. However, you have patients that you cannot use a mouthpiece with. A patient could be one that had a stroke. They're unable to hold this, or they're unable to keep their mouth closed or something on that line. And we're going to still give them the treatment, so we'll give them a mask to do it with. The mask we use is an aerosol mask. Why do people say they think the mouthpieces are a little bit better? Is because sometimes when you're using the mask, some of that medication does fall out and penetrate the nasal passages and never makes it down to the lungs. We have two types of these. One is mainstream, one is side stream. A mainstream is one that uses the gas support flow of the device that it's connected to. So it puts the medication right into that medication gas stream. Blah. And then we have a side stream, and the side stream is what you're looking at here. It has its own gas source, and the patient is delivering their medication from this source, and it's not in the mainstream at that particular point. Now, it seems kind of odd that this looks very, very simple, but some patients do not get the hang of this. They don't know how to use it. We teach them, we show them, put the mouthpiece in your mouth. We're going to show you how to breathe with this. I remember one time, and one of the questions you always want to ask is, do you know how to do this? The patient says, yes, I watched my grandson do it. We handed her the nebulizer, and what she did is she flipped the mouthpiece around and started to breathe in and out off of the reservoir tubing. So then we went in and said, perhaps we want to turn this around and let you use the mouthpiece. The other thing is this has to be kept upright. If you don't keep it upright, you're going to end up losing your medication because the medication will actually pour out of it. These, for the most part, are not portable. You're pretty well tied to your home or wherever you're receiving this. The other thing is not all medications come in the unit doses that we can use to go ahead and deliver our small volume nebulizers. So how do we do this? This is a slow inspiratory flow. What we do is we tell the patient to a certain extent, breathe normally for about 3 or 4 breaths. And at the end of the 3rd or 4th breath, take a slightly deeper breath, hold your breath for 2 to 3 seconds, and then go exhale. We want them to do this breathing pattern throughout the treatment. Okay? So we need to be there to coach these folks to do it. What'll happen is you're going to see the medication and the normal saline on the side of the small volume nebulizer cup. What you have to do during the treatment is tap it back off of the side, put it back into solution so they can come back up again. The first medication that leaves the small volume nebulizer is your normal saline. So you want to make sure that you tap it because you want to still mix the normal saline and the medication that's in the medication cup at that point. So it's just a matter of tapping it. Sometimes when we've had patients who've done this for a long time, like I said, we'll ask them, have you done it? Oh, I've been doing it for 15, 20 years. I'm really an expert at it. We'll say, okay, well, remember, tap your cup, and they actually beat the nebulizer up. So it's really kind of funny to watch that. Infection control, these need to be clean and disinfected during use, or at least rinsed with sterile water and then dried, okay, at this point. We don't want to leave these with any medication in there. The reason is if we don't empty that medication out prior to the next treatment, we add new medication on top of the old one. The old medication at that point has aged. It's been sitting around for 4 hours or so, and it's now aged at that point. It's something you don't want to do. So what they tell you, and when the Joint Commission came one time to the hospital, is they said, take a handful of alcohol wipes with you. When you finish the treatment, you empty it out, and then use the alcohol wipe to wipe the inside of the nebulizer. And this is basically how it works. You can see there's a compressed gas source, liquid in the reservoir. You have the ambient air who's coming in, and you can see up there it says drug loss during exhalation. It's also drug loss if you're not pulling it all in when you're inhaling, and that's why we like to go ahead and put that reservoir tubing on it. You can see the baffle is right above where that gas stream is. Anything on this really can act as a baffle. If the particles are hitting the side of the nebulizer, it can also break it down at that point. The little part on the bottom there, that little dark area, is what we call part of the jet system. If that part is removed from the nebulizer cup, the nebulizer cup is not going to produce any aerosol particles. How do we know that this happens? We go ahead, if we're not looking, we'll attach it to the flow meter, turn it on, and the medication just sits in the bottom of the cup. It may move a little bit, but it's not going to move very much. So we need to make sure all the parts and pieces are together. How many liters do we run this on? It actually depends on the manufacturer. You have some nebulizers out there that require 5 to 6 liters per minute. There's other nebulizers that require up to 10 liters per minute. So when you get your equipment, one of the things you want to do, take a look at the information on the equipment that's in the bag where the equipment comes from, and take a look at it. It'll tell you how to run this. This is one of the breath-activated nebulizers. This is a little bit more efficient than the other nebulizer, the small volume nebulizer you saw on the last two slides. This one, at the very top of it, if you look, has like a little round area. What you do, this is an older one, but what we used to do, this came with a small blue cap. And if you wanted to do continuous nebulization with this, you put the small blue cap over that little bump on the top, and it would press it down, and that put the nebulizer into continuous nebulization. If you wanted the patient not to have a continuous nebulizer, then basically what they had to do is they had to inhale enough to pull that little top piece down, and then the medication would be released to them. One of the things that happened with these, which is a really good thing at Banner and at the VA, is when they were given these medications, they limited the treatment to 5 minutes. And the reason they did is the patient was getting more medication. There's not much caregiver exposure with this. There is still a little. With the small volume nebulizers, there's lots of caregiver exposure because there's nothing to hang on to that exhalation mist. This is a Sprint breath-activated enhanced nebulizer. You can see you have the liquid medication, the gas flow. The liquid medication is broken into smaller particles, and there's your mist. You can see you have an inspiration and expiration through a mouthpiece, and when you exhale, it actually exhales from the top of the mouthpiece area. There's not that much of the medication that's getting into the environment. You also have on some of these a finger control. I've not seen this, and I'm not surprised though. And if you want to inspire, you just press it down. So instead of having the little area on top of the cap, this is actually just connected to it. And when you want the patient to exhale, you just release it at that point. You also can do continuous nebulizations. We can do these with kids quite a bit. We've tried with adults. Part of the problem with adults, though, is they get really bored with them after a while, and once they start feeling a little bit better, they want the medication to stop. So they'll either take it off if we don't do it, or they'll tell us that we need to take it off. This one is running off of a blender and a flow meter, and you have your IV pump, and you're dripping the saline into it, so you figure out how much of the drug you need to put into that nebulizer cup in order to be able to deliver that continuous neb. Then there's the Aerial Clips 2. This is a new one, very similar to the one I told you on the first part was the breath activated neb. BAN means breath activated neb, okay? The new Aero Clips, instead of having the little blue cap that you put on it, it had a dial that you actually just turn. And when you turn the dial, it told you whether or not you were getting single breath or continuous, okay? So basically, this tells you how to set it up. The actuator will start to move once the patient inhales. Negative pressure pulls the diaphragm down, around seals the nozzle cover, and produces the aerosol, and then goes ahead and allows the patient to exhale. And again, these are good because they're pretty well self-contained, so you have much, much less caregiver exposure. And this is just a picture that shows you how that works. The most common ones we use in the environment outside the hospital, in the hospital, are going to be your pressurized meter dose inhalers. These are much more convenient, portable, less expensive. They deliver a wide variety of medications. At one time, some of our medications only came either as a liquid, which went into the small volume nebulizer, or it came as a dry powdered inhaler, and patients had to be able to do the requirement for the dry powdered inhalers. Not all of them could. And then finally, the drug manufacturers started putting them into the pressurized meter dose inhalers. You do have to have coordination with this. You cannot activate it too late or too soon because you're going to end up losing your medication. So what we do to help folks, as you can see, next bullet is a spacer or valve holding chamber, and we can use that, and that helps the patient to a certain extent. A spacer is basically something that gives you space. I have a picture of some spacers coming up, and one of them is actually a toilet paper roll. And what you do is you just put the end of the toilet paper roll in your mouth, and you put the nebulizer at the MDI at the other end of it. And then you just use that as your spacer. A holding chamber actually holds the medication. We go ahead and we can put the medication dose in there. And when we do, it's in the chamber, and then it's ready for the patient to go ahead and take their breath. You have to monitor these for a number of doses that are in there. We've had patients who've come into the hospitals and they'll say, you know, my MDI is not working. And we're going, oh, okay, well, how long have you had it? Well, let me see, I got it in February. This is June. And we're going, well, the reason it's not working is it's empty. Most of these nebulizers, if you're going to hold 200 inhalations, if you use it 4 times a day, 8 inhalations, your nebulizer is only going to last for 25 days, and then you're going to have to change it out. What you see at the bottom, and this is also going to affect the number of doses, before you use a pressurized meter dose inhaler, you have to prime the inhaler. And how do you prime an inhaler? You basically set the inhaler up. When you set the inhaler up, you shake it, do all the things you need to do, go ahead and activate it, and the first 1 or 2, up to 4 inhalations are gone. A lot of the manufacturers build those into it, so you actually do get the 200 inhalations. However, if you haven't used this for more than 24 hours, a lot of the manufacturers are going to tell you that you have to prime them, and that means you're going to actually use 2 to 4 inhalations of that 200. So when you're figuring this out, you need to sit down with your patients and make sure, if they don't have a dose counter, I'm going to show you those, that they understand whenever you use more of the medication or you prime more often, your doses are going down, and therefore your MDI is going to empty much, much quicker. This is basically what an MDI looks like. You have the canister, the drug, the propellant, liquid mixture. These have to be shaken before they're used. Otherwise, you're just basically getting propellant at that point. So one of the things we do when we teach our patients is always shake this. You have an actuator, a metering valve, a seat, and then the nozzle itself. The newer MDIs that have the dose counters on the container, not the canister, but on the container itself, you cannot take that canister out because the dose counter is on that canister. And if you take it out of the plastic portion that holds it, you're going to lose or mess up your counter. So patients can't do that. So then the question comes up, well, how do I clean it? Well, you can clean the mouthpiece area, which is that longer portion of it, and then you can take a Q-tip, don't use them on your ears, wet it, and then just wipe the little area out where the actuator nozzle is, and that will clean it out for you. And this also shows you we can also use another device to be able to do this. This would be a spacer. This is something that we could see on a patient who's on a ventilator. We're going to go ahead and activate the dose and then go ahead and deliver it to the patient. If you remember from pharmacology, we've changed our carrier gases. We're no longer using CFCs. we're using HFAs. And what that did, it actually changed the nozzle stem a little bit. So some of our spacers, we had to go and get new ones because the old ones weren't designed to work with the new ones. So there's your dose counters. You can see some of them are on the top. Some of them you can buy and put on the top. It'll tell you the days and how many inhalations you took. Some of the counters are on the back of the plastic container that holds the canister, the MDI canister, and you just have to keep watching those to see how many puffs are left. I think what happens a lot of times, people get very comfortable with them and they have a tendency not to look and see how many doses have been used or how many doses are left. These canisters will tell you that, which is really, really good. This is the closed mouth technique. There's probably about 3 or 4 different techniques depending on what you're using. At one time, we told our patients you cannot put it in your mouth. If you remember, one of the things that affects drug delivery is inertial impaction. The larger particles impact on the back of the airway. Because of the HFAs, they're not quite as powerful as the CFCs. The new guidance that's coming out from the ARC is that these guys can use actually the closed mouth technique. You still have to coordinate your breath, and I'm going to show you how you can do that here in a minute. So how do we tell a patient to use the pressurized MDIs? If you're just using the closed mouth technique or you're using the 2-finger method, the 2 fingers is, you put on your lips and then you put your nebulizer out from the side of it at that point. You tell the patient after they've taken their nebulizer, if it's cold, warmed it up, make sure they shake it. Then they go ahead and hold the nebulizer up if they're doing it out of their mouth or put it in their mouth. Start your breath. As you start your breath, you activate the canister. Okay? The breath you're taking is a slow, easy, maximum inhalation. So you're going to have your patient exhale before they activate the canister and before they start that breath in. So it's really important to tell them, warm the canister up, shake it, go ahead when you're ready, exhale, either hold the canister out 2 fingers or put it in your mouth, start that slow breath in, activate the canister, and continue to drag the medication in at that particular point, okay? And you're going to hold your breath for a count of 10 seconds. When you're doing this, if your physician has ordered 2 inhalations, what you do is you do 1 inhalation, complete it, you wait about 60 seconds, and then you're going to repeat that. You're going to shake it, you're going to go ahead and, put it, are you going to use the 2-finger method, or you're going to use your closed mouth technique, exhale, put it in, do the same thing. As you start your breath in, activate it, and then you're going to pull the medication in. Coordination is the key to this, and some people unfortunately don't have that coordination. If you're using a spacer, you have a little bit more time to try to get the medication in. Works much, much better than putting it in your mouth or even using the 2-finger techniques. Like I said, almost anything can act as a spacer. And if you're using a holding chamber, as I told you, the medication is held within the chamber. When you look in your book, what Egan's is going to tell you to do is basically have the patient, especially if you're using a mask, it helps also because we use this with the children, have them breathe in and out 3 or 4 times. And that's 1 inhalation at that point. Most of the time with adults, we don't teach them to do it that way. We tell them to take that deep breath in, nice slow deep breath in, hold their breath, still wait for 10 seconds. Now, some of the holding chambers have a whistle built into them. If the whistle is going off, they're inhaling way too fast. So we need to tell them to slow down. Dry powdered inhalers, these are breath activated. You are the gas source. And you do have to have some coordination with this also. In this one, if you look, your particle ranges are 1 to 5 microns, perfect to go into the lungs. However, in order to use these, you have to have a fast inspiratory flow of 60 liters per minute. When they first came out, they would tell us it was anywhere from 40 to 60. Now they pretty well settled on 60. People that cannot use this include people who have bronchospasms. They cannot generate that type of flow, or children under 6 years of age, or another one, because they can't generate that flow either. If you have somebody who just cannot take a deep breath, say they had a stroke or something, then at that particular point, they're not going to be able to use the dry powdered inhalers. So what affects them? For the most part, as you can see, the intrinsic resistance, inspiratory flow rate, exposure to humidity and moisture. Do not expose these to your bathroom, okay? And then the patient's inspiratory flow. Basically, clean them. You don't take them apart to clean them. You can go ahead and still use that Q-tip to be able to do it. There's different types of DPIs. Some of them, you open the top and there's a like a mesh on it. And when you pull that portion up, you put it into a chamber. On either side of the chamber, there are 2 puncture areas. So what you do is you put the medication in there, you close the area that has the mesh on it, and then you go ahead and puncture the caplet that you put into it. Another one is that you actually turn it. When you turn the DPI, it goes ahead and activates and punctures the blister pack for you, and that allows you to go ahead and release the medication. You do not want to shake these. Ever don't shake them. You don't want to turn them upside down. The medication will come out. You don't want to blow into them, because if you blow into them, the medication is still going to come out. So you basically hold it horizontally. You can tilt your head back a little bit, and after you exhale fully, then you're going to take a fast deep breath in. Some people will tell you don't hold your breath. We're going to tell you hold your breath for at least 10 seconds. A lot of the DPIs only require 1 inhalation. And part of that is because of the way that we've mixed the medication in the DPIs. So these are some pictures of them. You have the turbohaler, you have the little caplets there. The rotohaler is there too, and the dischaler is at the back portion of it. And that was one of the ones that we carry a lot of our medications with. So this is one with powdered inhaler where you're going to twist the bottom. You can see how that works as the medication comes out. The discus, for the most part, you have the medication that's in there, and as you turn it around, it punctures the blister pack, and then the medication is released. The majority of these have a counter with them, so you have to keep an eye on that counter also. Some of them, like Spiriva, if it's coming as a dry powdered inhaler, every month when you get your Spiriva refilled, it has the little container, the DPI portion of it, and you get so many caplets. And so once the caplets are used up, then that's the end of it. You have to go get your new order too at that particular point. So on those, you don't need a dose counter because you have the number of caplets. These are some of the newer ones on the market. There's the Easyhaler, there's Elliptica, a Podhaler, and then Diffusora Pressair. So these are all brand new, but they all basically operate the same way. And here's the last one, the Spiral Max. This just gives you a look at how does this work. As you can see, you have the carrier drug static powder bed. It's dilated as you activate it. It goes through a mesh, and as a result of that, it breaks it down into the smaller particles. The newest one on the market is the Respimat, or the soft mist inhaler. It's a small handheld inhaler. It uses mechanical energy to create this aerosol from a liquid. It delivers the unit dose in a single activation. You can actually have 2 of these activations on there. It does require some hand-breath coordination. This is another one that you're going to have to make sure you shake. The little cartridge, as you can see, actually fits on the bottom of the major canister. And what you do is you take the plastic portion off the bottom, you put the canister in there, and you press it in. You sometimes have to press on a table or something, and then you'll put the plastic portion back on. And what it'll show you is that this is a complete filled canister and how many doses that you have with it. Once you prime it, you're good to go. As you use it, you'll notice that the counter goes down. Once it reaches 0, this doesn't work anymore. This prevents the patient from coming in and saying, I got this in February and it's now June 1st. And it just doesn't feel the same. So they're really, really good. Limited doses. One of them that started off as Combivent. If you remember, the Combivent is a mixture of albuterol and Atrovent. Spiriva is another one that's in this one, and we're starting to add a few more every day. Now, a question that we had at the beginning when these first came out is, do you need to use a spacer or holding chamber with them? Community was divided, yes, no. The latest research tells you if you want to, but most of the time you don't need that. So this is what it looks like. There's your mouthpiece, as you can see. So you're going to put that mouthpiece in your mouth, and then you're going to go ahead and activate it. You're going to see this really neat mist come out. And how it works for the most part, you have this little block, and it goes through this block. This is the instruction, much more detailed than some of the other ones, but tells you how to do it, how to activate it. This one tells you hold your breath for 5 seconds or as long as comfortable. 5 is good. Most of the time we tell folks 10. Why do we tell them 10? So that they don't get confused. Do I hold my breath 10 seconds here? Do I hold it 5 seconds over here? What's going on with it at that particular point. What I've done, if you go into course content under videos, I've attached a video from YouTube that shows you how to use a Respimat or soft mist inhaler. So how do we know what to give these patients? How do we select the device? And so the first thing we need to know is, how is the device, or how is the medication delivered? Is it an MDI? Is it a DPI? Is it a soft mist inhaler? Or is it used in a small volume nebulizer? For the most part, if the patient is able to use a metered dose inhaler, we will give that to them. And one of the things you're going to see with your patients is that they do like to use the MDIs over the SVMs. However, if your patient is not able to take that deep breath, there's major issues with coordination. Most of the time, we're going to use the small volume nebulizer. We may have to hold the nebulizer for them. We may have to use the mask, and that's okay also. But in those cases, we need to, because the patient's not going to be able to do it for themselves. You can also see on here too, it talks about reducing the oral pharyngeal deposition, especially with steroids. Steroids have larger MMADs. They have a tendency to rain out much higher. Remember, when a steroid has the opportunity, it will cause an infection. So we do have to watch that. And we need to make sure those patients, we tell them, rinse your mouth out and spit. Do not swallow the medication. And their nebulizers are the first choice when the formulation is only available as a solution or the patient is in some type of distress. And what we need to do is we need to talk to our physicians. When our patients are telling us, I'm not doing these SVNs, and you know that they still need to use something because you've done a good assessment on them, you need to talk to the physician and tell them we need to continue the small volume nebulizer. You need to talk to the patient and explain to them what's going on with it. Or we can make the recommendation, this patient's getting much better, they want to use an MDI. We think that the MDI will work well for them. It's probably time to go ahead and change the order to allow that use. So we have to understand, how does this equipment work, what's going to work best for that patient, and then we need to be able to discuss this with our physician. The last one we're going to talk really, really quick is your small particle aerosol generator, or your SPAG unit. Your SPAG is used to deliver ribavirin or Aerosol. If you remember, that's the medication we use for RSV. As you can see, it's a plastic box, and it basically is a plastic box. It has two containers in it. One of them is where we mix the medication. The other one is connected to it. That's the flow area. What happens is we mix the medication, we set the flow meters. There's two flow meters. It has to be a pressure of 26 psi when we set the two flow meters up. We adjust it with that little dark knob in the center. One of the flow meters is going to deliver the medication. The other flow meter is going to dry the medication out. And when we dry the medication out and deliver it to the patient, it's a very fine mist. If we're using this on mechanical ventilators, or we have to use a filter on the end on the general floor, that filter needs to be changed about every hour. Otherwise, you're not going to get medication through it. That fine mist is going to block up that filter. Remember too, with ribavirin, 3 to 7 days for the treatments, 12 to 18 hours. You as a therapist have to protect yourself when you're doing this. So things we need to look at: how do the patients use the SVNs, MDI, DPIs, SMIs? We need to know how to educate these patients. Always ask these patients, do you know how to use this device? Have them to explain to you how they do it. Some patients may get a little annoyed with you. That's okay. You still need to ask them and have them show you. If the physician has ordered a holding chamber to be used with the MDIs, you need to explain to them, why do you use this holding chamber or the spacer that the physician wants you to use? You have patients out there who are going to tell you that they've had 14, 15 spacers or holding chambers at home. They don't like those because they can't feel the medication on the back of their throat, and therefore they're not going to use them. So make sure you document all of those. We're going to document pre, post, and in between vital signs, heart rate, respiratory rate, breath sounds. We're going to see what happens with these patients. Hopefully everything is getting better. If the heart rate goes above 20 beats per minute, we need to stop the treatment. However, if a patient is really, really coughing badly, they'll tell you, don't stop my treatment, keep it up, because once I finish this treatment, then I'll be able to stop coughing. This treatment's going to relax me. And a lot of times that's exactly what happens. In our emergency rooms, we don't stop the treatments unless things are not going well. The patient's heart rate is continuing. Part of the reason their heart rate is continuing to increase is that a lot of times they're hypoxemic. Okay? And remember, the first line of hypoxemia is always tachycardia. So we need to give them these treatments to be able to relax the airways, be able to deliver that oxygen to them much better, improve their SpO2s, and then we should see the heart rates coming down at that point. Always keep in touch with your physicians in the ED. Always keep in touch with your physicians on the floor if there's something going on that they need to be aware of. Okay.